Good morning. I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it's my great pleasure to welcome Dr. Dhaval Kolte for this interview. Dr. Kolte, thank you so much for joining us today.
Thank you, Dr. Khalid. It's my pleasure to be here.
Thank you. So we are very excited to feature your publication titled Out of Hospital 30-Day Mortality After Mitral TEER, Insights from the STS-ACC TVT Registry. Now, we all know that TVT Registry provides a great platform. It's a huge database of so many patients with mTEER. So could you please provide how you use this registry for your analysis, the design of your paper?
Yeah, from January 2014 to April 2023. We had some inclusion and exclusion criteria. Mainly, we excluded patients who had missing information on in-hospital or 30-day mortality. We also excluded patients who had missing information on the cause of death within 30 days, and also some exclusions such as patients who had an aborted procedure or those in whom the mTEER was converted to open surgical mitral valve procedure.
Perfect. So could you then share the key findings of your analysis for the audience?
Yeah, so I would say there are three main findings from this analysis. First of all, we found that out of the approximately 61,000 of patients who underwent mitral TEER during the study period, 3% of patients died within 30 days after the procedure. And out of these patients who died within 30 days, almost 41%, which is 2 out of every 5 deaths happened out of hospital after discharge. Secondly, we found that majority of the out of hospital deaths were because of cardiovascular causes in approximately 61% of cases. And then third is we looked at we identified several independent predictors of out-of-hospital 30-day mortality and identified several non-modifiable as well as modifiable factors. Some of the modifiable factors being in-hospital complications such as major bleeding after the procedure, also the lack of ACE inhibitor or angiotensin receptor antagonist prescription at discharge. So those were some of the key findings.
Perfect. Thank you so much for your response, Dr. Coltis. So, and then finally, what insights do you think the clinicians can take away from these results? And then for the researchers, what potential directions for future research for them from this analysis?
Yeah, so I think, again, I would say there are three key takeaways. One is definitely patient selection is important. I think one of the independent predictors was greater than moderate residual MR after mTEER. So patients in whom the anatomy is borderline or where we think that the procedure may not succeed, even if we get some reduction in the MR, but not like an optimal result. I think those patients may be better managed with GDMT optimization alone, perhaps. The second takeaway was also to kind of optimize the post-procedural or procedural aspects. For example, major bleeding was one of the predictors of out-of-hospital death. So certainly that's something to modifiable. And another analysis from the TVT registry recently showed that even in the contemporary data, the rate of major or life-threatening bleeding after mTEER is about 2.3%, and it was also independently predictive of mortality as well as readmission at 30 days in that study. So our findings are also consistent with those observations. And then also in terms of the GDMT optimization pre as well as post-procedure, if patients are not on medications that we typically would use in patients with heart failure with reduced EF or even heart failure with preserved EF, then that optimization ideally needs to happen before someone is considered for mTEER. But if it hasn't if patients are not on those medications, that's important aspect as well. And then the final takeaway is certainly how these patients are followed up and managed after discharge. I think as the structural or valve programs are getting busier and busier, most of the times these patients are kind of sent back to their primary cardiologist for follow-up. And if there are any complications or concerns, then it may be a reason to make sure that these patients are being seen by the interventional cardiologist to perform the procedure at least 30 days and up to 1 year.
Perfect. Thank you so much for sharing those insights. Great points about patient selection, having these patients on appropriate medical therapy and appropriate follow-up as well. And so, yeah, thank you for sharing your results and congratulations on your work, Dr. Kolte.
Thank you, Dr. Khalid, and thank you, JACC Interventions, for this opportunity.